everyone. I'm April Jasper, and today I'm excited to welcome back Ann Morrison to our podcast. Ann is an assistant professor at the Ohio State University College of Optometry, where she also received her OD in 2014 and PhD in 2021. Ann is a fellow of the American Academy of Optometry, and today she will be sharing with us some of her work from the upcoming issue of Ophthalmic and Physiological Optics entitled Prescribing Patterns for Pediatric Hyperopia among pediatric eye care providers. So let me say that title again. Prescribing Patterns for Pediatric Hyperopia among pediatric eye care providers. Ann, thank you so much for being here.
Hi, thanks for having me back.
All right. So Ann, I understand this was a group paper analyzing survey data from practicing eye care providers. In fact, some of our listeners may have even participated in this study. Can you tell us what the goal of surveying these providers was?
Yes, so this, I'm certain many of the listeners have participated in this study, which we appreciate. We had, I think, over 800 people respond to the survey, which is wonderful. So it was a very large survey that was sent out to practicing eye care providers. And specifically, we were looking at pediatric eye care providers and how they prescribe for different conditions. So it did include myopia, astigmatism, but the one that I wrote about was on prescribing for hyperopia, specifically in pediatric populations, because as we know, prescribing for hyperopia is not cut and dry. A lot of our prescribing for our patients really depends on our clinical experience and what our understanding is of the needs for the patient. And unlike myopia, where we know just send them with full minus and walk out the door, hyperopia is not so straightforward. So this survey was sent out to give us a better understanding of where we are. Has more recent research changed the way we prescribe in optometry and also in pediatric ophthalmology, because we've often seen in the literature that pediatric optometrists and ophthalmologists often approach prescribing very differently and have different prescribing patterns. So this was meant to see what kinds of differences or similarities do we have between professions and also within our own profession to get a better idea of where things stand currently.
Okay, so now you're leading us very much into wanting to have answers. So
yeah, absolutely.
Can you give us a summary of the types of questions these doctors answered?
Yeah, so when it came to hyperopia specifically, the questions that were asked were mostly regarding different prescribing scenarios and what factors were important. So one of the first big ones was, what factors do you consider when you are prescribing for hyperopia? And the list was long. It ranged from patient symptoms, visual acuity, accommodative ability, how school is going, what was their refractive error in the past year. So they were allowed to answer the gamut of what symptoms they think about when they prescribe. We also asked, how much plus would you prescribe for an asymptomatic child with no other visual problems? Everything looks good. Acuity looks good. No strabismus from birth all the way up to 7 and older. And they did them in little age buckets to see how the prescribing patterns changed. And then the last series of questions was, okay, in older kids, 4 to 7 and 7 and older, when you have them in your chair and they have maybe a moderate to high esophoria, how do you prescribe for those kids? And then we asked, okay, in those 4 to 7 and 7 and older kids, if they have reduced near function, like reduced near acuity, reduced stereo acuity, what do you do for those kids when they're in your chair? So that we asked again, how much would you prescribe at different levels? And then we finally asked how prescribers typically pick their hyperopic prescription. Do they base it off of their cycloplegic ret? Do they base it off their manifest? Is it a combination of both? To get an idea of how doctors are thinking about things.
That's a lot, and it's all good.
Yeah.
So was there a consensus for prescribing? I'm going to guess no.
Yeah, you're exactly right. I mean, I don't think it's rocket science. I think all of us probably know this, especially our pediatric doctors. But I would say there was a big difference between professions, but also a wide range within professions. So for all of these questions that were asked, you'd have doctors that were much more conservative, prescribing at +1, and you'd have some prescribers who were not waiting to prescribe till much higher levels of plus. So there's a huge variation with all of these questions within professions. So within optometry alone and with ophthalmology alone. And then, of course, there were differences between optometry and ophthalmology. Among all the questions asked, optometrists generally start prescribing about 1.5 diopters to 2 diopters less plus than ophthalmology, which I think makes sense with our ways that we've been trained and how we manage hyperopia, but definitely a lot of variation. There were some similarities. I mean, in the question that was asked about what clinical factors do you think about when you're prescribing for these patients, really, I would say in most of the categories, more than 50% of each profession, optometry and ophthalmology, considered these factors with prescribing, especially in the ones that we think about a lot. So there weren't huge differences when you asked doctors to say what factors they considered, but then when you actually looked at, okay, here's the clinical scenario, how much and when would you prescribe? That's when the differences started to show up.
Well, I guess that leads us to, listeners are probably thinking, well, then what do we do? So I'm going to ask Anne, she's the one that's doing the research. What are the key points of this for our listeners, given these findings?
Well, I think this probably contributes to our frustration as providers that just don't know what to do sometimes. And let's be honest, one day you and I might prescribe one thing for a patient. They come the next day and I'm feeling a little more generous and I'll give them a little bit more plus. And I just think this is really a signal to how much we need to continue to support pediatric vision research. And I know myopia is really popular these days and myopia control. Listen, I understand, but I often think the hyperopes get neglected. And I think this is just a very easy way to show that we don't know the answer and we don't know what's best for these patients. And so we need more work to help us as clinicians know how to treat these patients, to help them have a better visual setup for their childhood.
I love this. And I think, I told you in one of the other podcasts that we recorded, I'm a hyperope. So knowing that as a 5-diopter hyperope, I know what I went through.
Yeah, exactly. And, that's the thing with kids, right? They think everybody sees like they do. And the fact is they don't know that it's a problem necessarily. And so it's important for us as optometrists to make sure that we're seeking these kids out, even if they don't complain.
And thank you for being here. And again, thank you so much for all the work and the research you do. We really appreciate it. I do, being in practice. I'm not the one that's always out there doing research, and what you do really does make such a difference for all of us.
Well, that's appreciated. Thank you so much for having me, April.